It can be tested in a way like father is saying something else and the mother is saying something else. So in that cases, you have to look what she wanted and you have to respect her wishes. Then the twin to twin transfusion, in this one detected by ultrasound screening and then Doppler flow analysis, fetal laser ablation should be done and all of this one. So one baby is bigger and the other baby is large. Here, the breech presentation in this one, you need to know which presentation is which one, and it can be given to you in the pictures. Not sure. Like this one here. This is breech presentation. This is a frank presentation. This is an incomplete presentation. So in this one, you can see the complete is basically hips and knee both flexed. Frank is hips flexed and knee extended. So this can be given to you that the hips is flexed, knees extended. What is this presentation and how will you approach it? Incomplete is basically both or one hip is partially flexed and both or one knee is present below the buttock. So in that case is then criteria for the vaginal breech delivery. So in this one of the most thing is basically here, the diagnosis, when and which time you are going to do. So usually frank or complete breech more than 36 weeks, then the fetal weight should be 2500 to 3800 based on the clinic or ultrasound assessment. In that cases, if the fetal weight is this much, then we go for that one. Then the fetal head flex, continual fetal monitoring to obstetrics should be there, allowed to perform a cesarean delivery within 30 minutes, mother motivation for the breech delivery. So the first three is very, very important. When more than 36 week, the weight and the head should be flexed. In those cases, we go for the vaginal delivery. Then the management is basically pre and early labor ultrasound to assess for the breech presentation, which one it is, then weight, growth, head flex, movement, all that. Then extracephalic version in this one. What are the contraindications of extracephalic version? One most important. What is the contraindication? The absolute. If you cannot remember the relative, at least remember the absolute one. What is that one where cesarean delivery is required? So placenta previa, we already know. We discussed that one, that in placenta previa, we usually go for cesarean delivery. Previous classical cesarean delivery, where the cesarean delivery, if there is a previous cesarean delivery, in those cases, we go for cesarean delivery. If there is a myomectomy, ruptured of membrane, uteroplacental insufficiency, like you can see where you feel like the if you do the vaginal delivery, the baby will die. In that case, is non-relative NST and then multiple gestation. In those cases, we don't go for ECV. We just go for cesarean delivery right away. Then they says risk are the abruption, cord compression, cord prolapse, rupture of membrane, labor, aluminization, then method is tocometry and all that. So do never forget about the ROGAM. ROGAM is something you have to write down, especially when we are talking about this one. ECV, we have to give. If mother is RH negative, give ROGAM after the procedure. If the mother is not mentioned in the if the mother is positive, negative, whatever is not mentioned in the scenario, you have to go for ROGAM in your answer as well. So although I said don't assume, but still for this case, you go for ROGAM and they are looking for you if you could remember the ROGAM. Then the better prognosis if multiparous, good fluid volume, then small baby, skilled obstetrician and all that. What is the vaginal delivery can be spontaneous or assisted, then encourage if the mother is looking for that one. What are the contraindications? The cord compression, footling breech. So just for your knowledge, you need to remember that footling breech, we don't go for the vaginal delivery. Cesarean delivery recommended if the breech was not descendant to the perineum. Then comes the hypertensive disorders of the pregnancy. In the hypertension, I usually you need to know you need to know the diagnosis, which one is pre-existing. If it's present before first trimester or it is present before getting pregnant, in that case, this is basically pre-existing. Gestation one is usually started after 20 week, okay, without proteinuria. Then comes the preeclampsia where there is proteinuria with the new onset of proteinuria or other side effects. So in this cases, which is basically this says there is one end organ. So if there is no proteinuria, but there is problem with the vision, we can still call it preeclampsia because this says with new onset proteinuria or adverse conditions like end organ dysfunction. So there is high blood pressure, but there is no proteinuria. It is a question, it can be asked this way, that there is high blood pressure, but she has no proteinuria, but she has vision problem or retinopathy or whatever it is. So she is having one end organ damage and she is having high blood pressure. So don't just restrict yourself with proteinuria. This is basically preeclampsia. Then comes the eclampsia where there is seizures and all that. The clinical manifestation of eclampsia is basically a clinical diagnosis when the patient presents with high blood pressure along with seizures or fit. This is basically eclampsia. Are tonic-clonic and lasting for 60 to 75. Symptoms may occur below the seizures, include the persistent frontal and then occipital headache, photophobia, right upper quadrant pain. So you can see there is end organ damage going on. Then 25% of the cases general with the woman typical eclamptic seizures who do not have the focal neurological deficit. You can see what are the adverse conditions. So if you could just memorize these ones, you might not forget the one we have already discussed, as we see that there's HELP syndrome, hemorrhage, renal, left ventricular failure. So you see placental abruption is there, DIC, pain, headaches, shortness of breath, chest pain, eclampsia. Then the fetal condition is IUGR, oligohydramnios, umbilical artery, and then can cause the fetal disability. So risk factors, we already see the risk factors. Then the clinical evaluation of the hypertensive disorder. Sorry, did we see that? Yeah. Then the clinical evaluation of the hypertensive disorder in this one, what could be the body weight, CNS, vision, hematological, hepatic, renal, fetal movement. So it's very, very important if you need to remember how you're going to evaluate the fetus. If you need remember these 5 things, you will be good for whole obstetrics. So just for your idea, how do you check the fetus? What is the one thing? Fetal movement. What is the second thing? Fetal heart rate by mother and by NST both. Then ultrasound. Then the BPP, biophysical parameters, those ones. Then comes the Doppler flow studies. So if you remember these 5, you can fit them anywhere where you feel like it will start making sense to you, where you are going to check for the movement, where you're going to check for the heart rate, where you're going to check the ultrasound. So just remember these 5 and then implement them wherever you could. Here's something. There's something here. Calcium supplement is recommended for the woman with the low dietary intake of the calcium. So we give the calcium to the female where there is low dietary habits. So in that cases. Then again, everything is written same, what we already discussed, when you are going to give the steroid, when you're going to give the magnesium sulfate, antihypertensive exercise. So we already discussed this one. If you keep thinking and memorizing those ones, it will start making sense to you now at which point what you need to do. Then coming the hypertensive, you're going to do the CBC. So don't forget about the HELP syndrome whenever we are talking about hypertensive. Believe me, for me, I forget HELP syndrome whenever we are talking hypertensive. That's why I'm telling you, keep it in your mind. For hypertensive, HELP syndrome should be your one of your diagnosis and keep it in your head. So that's why whenever you do a blood work, you have to do PTINR, checking for the AST, ALT. Why are we doing it? So checking for the HELP syndrome. So if you don't do ALT, AST, the other person will get an idea that you are not considering HELP syndrome in this patient. May consider the fetal growth and then all of this one. Complications could be the seizures, abruption, and left ventricular DIC, HELP syndrome, as we discussed, the HELP syndrome, IUGR prematurity. How you're going to assess the hypertension, the most safe drug is labetalol. Usually we go for labetalol regardless of everything. Then nifedipine, hydralazine, methyl dopa, all of those ones. Don't go for ACE inhibitors, herbs, and diuretics. Then coming the management of preeclampsia, in those cases, what do you do is stable. If no adverse conditions, in those cases, you have to see if the delivery should be possible or should we keep the pregnancy. Antenatal corticosteroid should be considered. We already discussed 22 to 35 week. So then if the more than 37-week delivery is recommended, preeclampsia stabilize and liver. Then preeclampsia during the labor is increased monitoring, overly output, urine, neurological, because and organ damage could be there. Antihypertensive therapy, then seizures, which is basically prevention, magnesium sulfate for the neuroprotection, postpartum hemorrhage, risk of the seizure, and then for the don't forget about the HELP syndrome, then normotensive BP within 2 weeks. How do you go for eclampsia? Eclampsia is basically emergency condition. You go start with A, B, C, airway, breathing, circulation. Then roll the patient to the left, let bilateral decubitus position, then oxygen, antihypertensive management. So now you already did everything. Now you have to focus on the convulsions. So prevention of the recurrent convulsions, you have to go for the magnesium sulfate. So if they ask for one drug, it's basically magnesium sulfate. But if they ask for one blood pressure pill, that's basically labetalol. Yeah, coming back to iron deficiency, folate deficiency. So folate do causes neural tube defects. In those cases, we go for folic acid, and then iron deficiency causes what are those ones? Everything less. So everything that is decreased. IUGR, low birth weight, hypoxia, preterm labor. So everything will be decreased. Simple. Then coming to the diabetes mellitus, in diabetes, don't forget about IUGR because we do have an idea about the macrosomia, but type 1 diabetes causes IUGR. It's a very straightforward thing and it can be asked, so we usually keep it in the mind. Here you can read what are the main goals, how much you want to keep. Then the preconception, pre-plan, and then high risk clinic. Then folic acid should be given. It's very important. The prevention is basically folic acid, along with the hypoglycemic should be less than 7%. And whatever ACE, herbs, statins, everything should be discontinued. Type 2 diabetes. And then what is the safe medication for diabetes? Usually we choose metformin and it says that it's metformin, but from whatever I have idea, usually we discontinue metformin, glyburide, whatever it is, and go for insulin directly, straightforward. So in the scenarios, if they ask for anything, the answer is insulin, the medications, okay? Type 2, switch to insulin therapy and discontinue any kind of insulin, okay? Because they're teratogenic. Tight glycemic control may be adjusted as the pregnancy advances, then monitor for the normal pregnancy. Then the increased fetal surveillance is increased. So you have to look for this line, very important, starting for the late T2 and T3, perform weekly at 34 to 36 week. Then the fetal echocardiogram is very important because in this case, we check for the heart as well. Why? Which cardiac abnormality is common in the diabetes? Look for that one, okay? Which cardiac abnormality is very common with the diabetes? Then the start aspirin as well to at night increase the 16 week to reduce the preeclampsia. So you have to start the aspirin. So what is the prevention or what do you have to prevent in diabetes? It's basically preeclampsia. Postprandial glucose values seems to be the most affected determining the likelihood of the macrosomia. So two things that you have to remember. One is insulin. Second is the fetal surveillance is increased and echocardiogram, what is the heart condition that is linked with the diabetes. And then the third one is starting the aspirin to prevent the preeclampsia. Then you have to deliver is basically 38 to 39. Don't go more than that because the baby is already big and it will cause complications. Postpartum, you have to check for the insulin requirements dramatically drop with expulsion of the placenta. That's why I said the hypoglycemia is very important because with the placenta expulsion, the hypoglycemia is there. Monitor for the glucose. Then the screening and diagnosis, you have to remember them. There's no shortcut to this one. I could not find. If you have, go for it. All pregnant women should be diagnosed between 24 to 428 week. The diet modification, checking for insulin, metformin can be used in pregnancy, but it's off label. So that's why we don't go for metformin. Serial BPP at starting at 36 week, whether you are checking for the fetal well-being. And please don't forget about the heart condition. Induction of the labor at 38 to 40 week. Encourage the breastfeeding for 3 to 4 months postpartum to prevent the childhood obesity and then diabetes. Repeat testing for the woman with the previous pregnancy affected with the, if there is anything related to previous pregnancy in the next pregnancy, we do look into that thing and we do prevention for that. Then the risk factors for GDM range age more than 35, obesity, risk indigenous is very common. Then the diabetes mellitus, history of GDM, child birth weight more than that, and the PCOS, glucocorticoids, essential HTN. Metformin and glycerides are safe during pregnancy, but not during, breastfeeding, but not during the pregnancy. What is the complication of diabetes in the pregnancy? I It's very hard to memorize everything, but at least keep it in your head that what could be the most important. So let me highlight the most important, but it's very good if you could remember everything. Now, starting with the obstetric, what are the complications with the diabetes? HTN or preeclampsia, that's why we started the aspirin. Okay. Then the polyhydramnios is very, very common. Okay. Which leads to the fetal hyperglycemia and then later on causes hypoglycemia. Then diabetic itself emergencies. So hypoglycemia, ketoacidosis, and diabetic coma. Then retinopathy, nephropathy, polynephritis, and then glycemic control. So for mother, if you could remember this one. Now coming to the fetus. First, we remember the macrosomia. That's very common and you can memorize. I know that. IUGR, I keep on highlighting. I hope this stays in your head that IUGR is also linked with the diabetes. Then one of the most important, it causes RDS. It says fetal lung immaturity, but the word you need to remember is RDS. Okay. Then one thing here, if it's a type 1 diabetes or type 2 diabetes, or it is a gestational diabetes, if this is type 1 or type 2 diabetes, it means it was there in the first trimester. Then it will affect the organs. And I told you which heart condition, it was VSD that we were talking about. VSD, the ventricular septal defect, is very, very common in the diabetes. So highlight this word. That's why, because we do the echocardiogram to rule out this one as well. So it can be asked like, why do you do echocardiogram, or which heart condition you want to rule out, or whatever it is. So VSD. Then it can causes the anal atresia. Like the anal part is basically blocked. So they might have to come up with a constipation, or she did, or the baby did not pass the feet meconium and now coming. So in that cases, you have to look for this one. Pregnancies complicated by gestational diabetes do not manifest an increased risk of congenital. But if they are type 1, type 2, which was previously there in the first trimester, then they have the analatresia, ventricular septal defect. So don't link this with the gestational. It is basically type 1 diabetes that causes the VST, analatresia, saccharinogenesis. I hope this makes sense. This is an important question that it can be asked, like what is the congenital anomalies linked with the which diabetes mellitus. So it's not the gestational diabetes, it is the type 1 or type 2 diabetes mellitus. Then it can cause preterm labor. So we know that. Then blood trauma, hypoglycemia, one of the most important thing I told you. Once the baby is born with the diabetes, why she and many of the babies do die because of the neglection of the hypoglycemia. So hypoglycemia, hyperbilirubinemia, hypocalcemia, and polycythemia. And this is a straightforward thing that what could be the consequences, or what is the findings in the neonate in the diabetic mother. So it's not hyperglycemia, it is hypoglycemia, hypocalcemia. That's why I said if you cannot remember anything, at least keep it in your mind that hypoglycemia and hypocalcemia could be anywhere. Then hyperbilirubinemia and polycythemia. So don't forget about polycythemia as well. It's the exam thing too, okay? The polycythemia. Then comes the most important thing that I would suggest, at least something can be touched from here. Okay. The early onset of GBS is because we don't have enough concept for this one. Just for your idea, if there is a previous case of GBS and this pregnancy, if the case is unknown, you have to treat the baby. You have to give the antibiotics. So before than this one, we have to know in which cases we go for antibiotics. So prevention of prenatal, each and every single word from this table is important. Then what happened is previous infant with the invasive GBS, we go for antibiotics. GBS bacteriuria during any trimester of the current pregnancy. Then positive GBS, vaginal rectal screening was there. So you are already discussed with this one. Then unknown GBS status at the onset of the labor, so you don't know, you did not do any culture. In that case is there was a positive GBS in the late gestation during current pregnancy. So in this one came out that GBS is positive in the late gestation, like in third trimester, but previously you did not even know. In that cases you have to give her prophylactic antibiotic, because this is very important in which cases we have to give antibiotics. Not every case will get antibiotic. Then if the delivery is basically less than 37, amniotic fluid like pre-prom, intrapartum temperature like fever, it gives you an indication, and then intrapartum nucleic acid amplification test shows positive for GBS. So one thing we can make sense, like temperature is there, amniotic fluid is there, delivery is late, GBS is positive, but the main thing is unknown GBS status, but in the late gestation it came out positive, or previous pregnancy has the GBS, or there is a GBS bacteriuria going on. So this is something that can be as like unknown GBS status could be linked with many things. So you need to know in which unknown GBS status you are going to start the prophylactic antibiotics. So as you can see, offer screening to all the females from 35 to 37 week. Then the prophylactic antibiotics, the penicillin G should be given, or the vancomycin should be given if there is a prophylaxis, penicillin allergy. Now, if maternal fever, broad spectrum antibiotic coverage, needles of GBS, and then gestational age is advised. So if there is a fever, regardless of anything, we usually give antibiotics. If this is less than 37 week in the labor with rupture of membrane, then in those cases we go for IV GBS antibiotic prophylaxis for minimum of 48 hours and then go for delivery. This is important. IV GBS should be given for minimum of 48 hours. I hope this makes sense because there is certain words here which is kind of very sketchy and very picky. So this can be asked like 48 hours, how long you have to wait after giving the antibiotics for the delivery, in which cases will you go for delivery, this is there, are you going to give the antibiotics? Because here we are very like we don't go for antibiotics right away. So you need to know in which cases we go for delivery, antibiotics during delivery. Then when we were discussing the UTI, we already discussed that if there is a asymptomatic bacteriuria, in those cases you have to go. Why? Because of the preterm labor. So if you see that we've already discussed this one, preterm labor. So that's why I said if you remember the things in the start, it will start making sense to you slowly by slowly, because many things are repeating over and over again. So dysuria, urgency, frequency, obviously it could be there, but if there is asymptomatic, still we go for the urine analysis, renal function test. On complicated, go for amoxicillin. Even for complicated, we go for amoxicillin. That's basically IV. Then major organism responsible for pyelonephritis is E. coli, Klebsiella, and then Enteroparetus and Proteus. It can cause acute cystitis, pyelonephritis related to kidneys, but the most important is possible PTL. And reoccurrence is very, very common. And you have to tell that in pregnancy, the vaginal flora are altered. That's why they might got in this infection. So they have to take care of all that counseling. Then we are talking about the infection during pregnancy. The infant's immunity begin to develop at 9 to 15 week gestation age. So response to the infection, mother and IgM production. Then we are talking about chicken pox. In this one, usually we give the management. How do you do the management? The varicella zoster immunoglobulin for the mother if exposed. So it is important. So because it is live attenuated, so we don't give vaccine. What do we offer? Immunoglobulins. Cytomegalovirus, non-specific treatment, just avoid high specific contents. Then erythema infectiosum, like fifth disease. If high drops occur, then consider fetal transfusion. Then hepatitis B, we have to give one at birth, 1, 6 or month. But if the mother is hepatitis B, in that cases we go for the at birth. You have to give her the hepatitis B. Okay, at birth we have to give, or the neonates with the immunoglobulin and vaccine both. Okay, so for mother it's different, for father it's different. We already discussed for the mother we do give her at birth as well. Then herpes simplex virus we give acyclovir and suppressive therapy for 36 weeks. Then HIV, in this one we go for triple therapy or triple retroviral therapy, decrease transmission, and then we have to do the cesarean delivery. Then the rubella, no specific treatment, offer vaccine after that. Syphilis, in this one we go for which one? You cannot write down penicillin. You have to write down benzathine, or you have to choose benzathine penicillin G. Okay. Then no approved alteration in pregnancy. Then toxoplasmosis, self-limiting influenza, and this is basically immunization with the inactive influenza. So what you need to remember, the most important is varicella one, because in this one we give immunoglobulins. The hepatitis B. In this one, we also give the immunoglobulins. Then the herpes simplex virus. In this one, we give the valacyclovir. And in HIV, we give the triple antiretroviral therapy. Otherwise, everything has the same. And syphilis, we give the benzathine penicillin. Otherwise, everything has kind of similar. Then the venous thromboembolism, the compression stocking and all that. So hypercoagulopathy and then venous stasis and endothelial damage. So with venous thromboembolism, pulmonary embolism, or amniotic embolism is there. So keep it in your mind. So before initiating any therapy, we go for low molecular weight heparin and fraction heparin. Then warfarin is contraindicated. Then VTE prophylaxis go for compression stocking, giving the unfractioned heparin regimes. Then postpartum thromboephylaxis should be given in absolute any of the following. So BMI more than 30. In that case, is smoking where you feel like that could be the postpartum thrombophylaxis could be there. So the complication that you have to keep in your mind is basically current prophylaxis regime for acquired APS could be there. So that's why I give the low dose ASA in conjugation with the prophylactic of heparin because antiphospholipid syndrome could be linked with this one. In that case, we have to give this one. So if you want to go into very detail of this one, go ahead. But usually what you need to do is basically keeping in your mind that you have to give the low molecular weight heparin and it discontinued after 24 hours prior to delivery. Then the unfractioned heparin and then warfarin is contraindicated for the VTE prophylaxis. Usually we go for those cases where you have to keep the mother like she could have the thrombophylaxis like smoking, placenta previa, IUGR, mother is obese on those cases, sorry. And then APS, keep it in your mind. How you keep it in your mind that HELP syndrome is related with the hypertension in or embolism, you have to keep it APS in your head. So in that case, we go for aspirin plus heparin. And if they ask which heparin is better, the unfractioned one or the low molecular, the unfractioned is better or compared to suggested over this one. And where is it written? Women with the non-active PMA, the unfractioned heparin regimes is suggested. So non-fraction is preferred over the low molecular one. Then the normal delivery, why I say normal delivery, I feel like you need to know the normal delivery. It's just, I just don't like this topic. That's why I don't feel like reading it. But I would suggest go watch some video, watch some picture, then it will start making sense to you how the normal delivery works. Because by reading, I don't know, it just never makes sense to me like how after these steps get to this step. Because like when they ask in the exam, they don't ask something straightforward. They do like to ask you from, from the side, how do you do this? So if you are following a normal step, then okay, yeah, we're going this, then we're going this, then we're going this. But if someone try to do or come from the right or left side, then it does not make sense that why are we going for this one. Okay, so preterm, term, and postterm. Preterm is 20 to 36 week, then term 37 to 41, and then postpartum. Now comes to the BISOP. This is basically the dilation, effacement, consistency, position. Just keep it in your mind. That's it. Then the fetus. Fetus life, fetus presentation. So which one is which one? I think we already discussed these ones. Uh, then the position OA, OP, OT. Why? In this one, you need to remember the most common is OA. Left OA is the most common one. Then what causes the prolonged second stage of labor? OP. Okay, OP causes the most prolonged stage of the second labor. That's it. Then the attitude, the brow presentation and the face presentation. The brow is the head partially extended and the face is basically head fully extended. Then the station is, we know the ischial tuberosity above and below. Then the asynchronism, this is basically alignment of the sagittal suture. So for this one. So occipitofrontal, the right occipitals, the occipito anterior, posterior, the left occipito anterior, and the left occipito, right occipito posterior. Now comes the 4 stages. Okay. The course of the normal labor, the stage, then nulliparous, and then multiparous. So for your idea, the nulliparous usually takes a lot of time, then multiparous usually does not take a lot of time. So for you, why you need to remember, because the time can be given and ask you if it's a prolonged labor or not. So for first one, it's in the first trimester sorry, the first trimester, the first stage of the labor, it's basically 6 to 18 for nulliparous. For multiparous is 2 to 10. So if it takes more than time, then it means the prolonged stage of labor. Okay. Then comes the latent phase. The uterine contraction is there, infrequent, irregular, slow cervical dilation in active phase. How do you decide that this is active phase? And it can be asked in the exam which stage it is. Okay. And just not knowing the first stage, second stage, you need to know it is a latent phase of the first stage. So if for your idea, the latent phase is like not very strong phase. So it's a very infrequent, irregular, like a very slow whatever is going on. And usually the usual cervical dilation is up to 4 centimeter. So only 4 centimeter. Now, if they mention that is more than 4 centimeter, now it gone above the latent phase. Okay. So active phase is basically rapid dilation to the full dilation. So now what happened is more than 4, it gone to more than 4 centimeter. So phase of the maximum slope and then painful regular contraction, and the contraction strongest at the fundus. So it's now the contraction is very, very strong. If they say the contraction is infrequent, irregular, slow, and that is basically latent phase. The contraction is strong, it's basically active phase, and then dilation is more. So here we were looking for two things, contraction and dilation. Now the second stage is now it's more than 10 centimeter, and then the baby start coming out full dilation, and the mother feels a desire to bear down or push the baby outside. So in that cases may choose a comfortable position, upright or left lateral decubitus position, measurement of the by descent. The third stage where the baby is already out, the placenta is out and everything. So usually the problem comes in the second stage of the labor where there is a prolonged second stage or whatever is going on. What are the signs of placental separation? They can ask you, how do you confirm that the placenta is already fully out? So gush of blood, lengthening the uterus, and then fundus rises. So active management is basically starting the oxytocin drip or giving IUIM or 5 mg IV push after the delivery of the anterior shoulder of anticipation of the anterior delivery. Then the oxytocin administration in the first stage of the labor can reduce the risk of PPH. Then the fourth stage of the labor is first postpartum hour. Monitor the vital signs and bleeding, then repair the laceration, ensure the uterus is contracted, inspect the placenta for competence, like checking for the placenta. If there is two arteries, one vein is there, third and fourth stage is the most dangerous where the hemorrhage could happen. So for your idea, you need to at least keep in your head the second and the third stage. First and fourth start making sense if you could memorize what is happening in the second and third stage and what could be the complications. We will do go into very detail of that one. Uh, but just for your idea, which medicine you have to give is basically oxytocin IV drip. Okay. So then you can see the head floating in engagement, how it's coming down, complete rotation, complete extension, resuscitation, delivery of the anterior, and then delivery of the posterior shoulder. Then let's least finish this one. Analgesics and anesthetics techniques. What are those ones? The heat and cold compression, immersion, touch and massage, tense, intradermal injection, aerotherapy, hypnosis, analgesics, biofeedback, nitrous oxide, narcotics. So just for your idea, just give it a read. Perinatal infiltration and then anesthesia in that one. So we usually go for this one. For fetal monitoring and in labor, it's a very extensive topic.